Mr. Kahara, how are you? Am I audible?
Hi, Mukosha.
Oh,
Yes.
okay. I don't know. My camera is not switching on. Ah,
eh, Let me try and change a few settings over here.
all right. Okay. Thank you. Good evening, everyone. It's 19 hours, and we are about to start. Mr. Elvis, has the camera been rectified?
Hi,
Oh,
Mukosha.
no.
So I've tried to change to work on the settings on my end. I'm not sure why it's not working, and I think we'll do some troubleshooting after the session.
All right. Okay. Thank you very much. Okay. So we'll wait for 5 minutes to allow more people to join, and then we can start. Mr. Kahara, how are you?
Hi, Mokosha. How are you? I'm well.
I'm okay. I'm okay. Unfortunately,
Yeah,
my camera is not working for me, so
sorry,
we'll
but we
try
can see
again.
some images.
Really?
We can see
Or
some
maybe
images at the back.
it's
Yeah,
it's the back camera that's
it's
working.
the back camera. Oh, okay. No worries. No worries. So probably we can wait
Mhm.
for 5 or maybe two
Okay, all
minutes and
right.
then we start off. Yeah.
Okay. I've switched off the camera. Are there some images? Are
No,
there
no,
some
no.
images
No
that
more
you're
images.
seeing still? All
No.
right. Okay. We can wait for 5 more minutes, then we can start. Thank you very much.
All right.
Okay. So good evening, everyone. This is 1905, and we we added 5 extra minutes to allow more people to join, and I think 40 is a good number to start. My name is Mukosha Kalunga, and I'm the host for the discussion. Today, I have a very good online friend who is helping us, who's going to take us through the risk management process. Our discussion today is titled From Concept to Practice, Applying Risk Management in Clinical Laboratories. And Mr. Paul Kawhara is going to just take us through so that we learn more about risk management. As we all know, the ISO 15189 2022 version has more than emphasized the practice of risk. So we're going to understand the concept and application of risk in the time that we have for the discussion today. So you can, if you have questions, you can post them in the chat box before we open the floor for questions. And when we open the floor for questions, you can just raise your hand and you'll be picked for you to ask your question. Right now, I'm giving the floor to Mr. Kahara, and he will introduce himself, and we'll dive into the topic. Mr. Kahara, it's your floor.
Okay. Thank you, Mukosia. Good evening, colleagues, wherever you're getting us from. Thank you for joining us. My name is Paul Kahara. I come from Nairobi, Kenya, and I'm so honored to participate in the discussion today with you, Mukosia, Elvis, and the entire team from Lusaka in Zambia. We'll be talking about the application of risk management in clinical laboratories. But probably before we get there, I just want to thank you for finding the time, colleagues, to join this discussion. And thank you, Mukosia, also for finding a chance for me to participate in this discussion. I live here in Kenya, although we work in various places across the country and across the continent. I lead a team at Ranqual Consulting Group as the lead consultant for quality management systems and occupational health and safety. That is basically what we do, particularly for healthcare organizations. And I'm glad to have done this for quite a number of years now. So allow me to stop at that so that we can go ahead and discuss this subject. But probably once we get another chance, probably we say more about what other things that we do. But just to mention that I also do assessments with the Kenya Accreditation Service as a technical assessor for ISO 17043 for PT providers, as well as ISO 15189, which is a standard that guides on global best practices for medical laboratories. So for all who are joining, you're welcome. Karibuni sana, as we say it here in Nairobi. We are happy to have you on board. So in the next 20 or so minutes, I will be engaging all of us on this subject of risk management. And I will just discuss three things. First, we'll do a quick introduction into risk management very briefly, because most of us have had an opportunity to hear what is risk, what are some of the requirements and all that. We will then quickly look at the requirements of ISO 15189 when it comes to risk management. And at the same time, we'll also try to look at some of the possible approaches or methodologies or measures that you can put in place to demonstrate that you're able to comply with the requirements of ISO 15189. And then thirdly, I will share with you a tool that we are using to make sure that this concept of risk management is applied in clinical laboratories. And then at the end, we'll open the session or the forum so that anyone with any question can forward it to us. Remember, this is the discussion. And so I want to speak little and hear from you as well, so that we can interact and engage on this subject. So we will be guided by the requirements of ISO 15189, the version of 2022, as well as ISO 22367, the version of 2020, not 2022 as indicated, which is the ISO standard that guides on medical laboratories application of risk management. So these are the two standards that we be talking about as we continue with this session. So welcome. Let's now get into the details of the subject of the day. We have heard about risk many times, not just in medical laboratory practice, but even in our activities out of the lab, out there in the field, in the streets, in the hotels, in various places where we go. We have had this term, risk, and that is what we'll be engaging the entire discussion today. So risk, generally speaking, is any anticipated negative impact to a process, a system, or an organization. Basically, it is anything that can go wrong, anything that will have negative consequences is what we refer to as a risk. Now, in healthcare, where we are all operating from, a risk is the possibility of occurrence of an event, an action, a condition, or an incident that could harm a patient, a staff member, a visitor, an organization, or disrupt healthcare service delivery. So anything that can cause disruption, anything that can lead into an incident, anything that can lead into a condition where we are saying things are not working the way they should is what we refer to as a risk. And in other words, we can say that a risk is any potential failure or any potential deviation, any potential nonconformity, any potential incident, or any potential accident. Remember, we refer to it as a risk if it hasn't happened. If it is still in the potential stages, if it is still in the possibilities, we will refer to it as a risk. You see, the risk of blood transfusion reaction, the risk of a power outage, the risk of needle prick injury, the risk of reagent stockout, the risk of EQA or IQC failure. If it hasn't happened, and from our understanding is that if it happens, it will cause a disruption or an incident, then that is going to be referred as a risk. And I believe you have heard about this so many times. Now, many people confuse risks and hazards, but I want us to agree today or tonight that a hazard is any agent, any source, any condition, any situation that has the potential to cause harm to a patient or a staff member or the environment generally. So anything that can lead into a risk, into anything that predisposes our situation or our environment or our daily operations into an incident is what we call a hazard. And so you can have biological hazards. You see, if you're working with samples contaminated with hepatitis B surface antigen or hepatitis B virus, then would say those samples are hazards. If you're working in a histology section and you have all these chemicals and formalin being one of them, then we'll say that you're working with some hazards. It is not that they have caused any incident or any accident, but they have the potential of leading us into that incident. But for the sake of this discussion, we will engage more about procedural or practice hazards. Like whatever we do in our facilities can potentially be a hazard. So for example, wrong technique of blood collection we know this is a hazard because it can lead us into an incident. So a wrong technique of blood sample collection, a wrong technique of microscopy, it's a hazard in itself because it can lead us into an incident. Now, an accident and an incident, these are two terms that most of the cases they are confused also. But let's also agree that an accident is any unplanned event that results in harm, injury, illness, or damage to a patient, or a staff member, or the organization, or the environment generally. But an incident is any unplanned event that could have resulted in harm of the patient or the environment, but it didn't. So probably it's only caused a minor consequence. So that's what we call an incident. It had a possibility of causing harm, but it didn't end up causing an actual incident, but probably it caused just a near miss. An unconformity, we know this is any deviation or any non-fulfillment of a requirement. Now, if we don't manage the risk, the possibilities of this happening, then you are going to end up with the incidents and the accidents. If we don't manage the risk, then you're going to end up with an accident or an incident. And the same incidents, blood transfusion reaction, if it actually happens, we will not call it a risk anymore. That will now be an accident or probably an incident. If a needle prick injury finally happens, it stops being a risk and transits into an incident or an accident based on the degree as we have described in the definitions above. Now, so the relationship between then the hazards, the risks, and the incidents is as indicated that, for example, if we keep issuing unwarranted, unnecessarily giving out whole blood instead of packed cells, that is a hazard in itself. It's a hazard. And then a risk will be the possibility of a blood transfusion reaction happening because of these hazardous activities that we are engaging in. And if finally, because of the issuance of whole blood unnecessarily, we end up into an incident, so we are going to have an occurrence of a blood transfusion reaction. So a hazard predisposes the system into the risk. And if the risks are not managed properly, we end up with an occurrence or an incident, an accident, a deviation, a failure, or an unconformity. So that is how the process looks like. We begin with the hazards, which predisposes our systems into risks, which if not controlled and managed, we end up into incidents and accidents. So the reason why we are engaging in risk management is to make sure that these hazards, because hazards are always with us, don't graduate into risks and then finally into accidents or incidents or deviations or so and so. So risk management generally is the systematic application of management policies, procedures, and practices to the tasks of analyzing, evaluating, controlling, and monitoring risks. So the entire, ecosystem of how we use procedures, how we use policies, how we use our daily operational practices to make sure that we're able to analyze our risks, to evaluate them, to control and to monitor them is what we are referring to as risk management. And that is a process of risk management that we are going to discuss in a few slides that are coming. If you have interacted with ISO 15189, you must have seen another term, opportunity for improvement. In some setups, they just call them OFIs. So an opportunity for improvement is any anticipated positive impact to the process, to the system, or to the organization. And what we are saying is that these are identified chances or suggestions to make a system, a process, or an outcome better. So when we talk about opportunities for improvement, these are chances we can take advantage of to bring up a better way of doing things. So it is not because something have gone wrong, or it may potentially have gone wrong, but because we want to do things better. That is why we want to initiate or to identify the opportunities where we can improve. So for instance, if you want to manage your queues, probably you have overcrowded patient receptions at our laboratory, and you decide to introduce, an automated queue management system. There is nowhere in the standard where we are required to have a queue management system. But for the sake of order, for the sake of serving our patients better, for the sake of improving the patient experience, we are going to introduce this queue management system. And so this queue management system is going to be an opportunity for us to do better, for us to organize our clients in a better way. If, for example, in your phlebotomy area, you decide that, we don't want to do try and error, trying to get the veins, and you end up, considering introduction of a vein finder, this gadget that is able to tell us where the vein exactly is, then that is going to be an opportunity for improvement. There is nowhere in the standard where we are required to have it. But for the sake of, serving our clients better, making sure they're not exposed to more harm, then we can go ahead and get this kind of a gadget. So these opportunities can be identified through different mechanisms. They can arise from risk assessments, where an additional mechanism to prevent a risk will probably be introducing an opportunity for improvement. They can be from patients, from users, feedbacks and complaints. They can be from our own personnel feedbacks. They could be suppliers' observation. Sometimes the supplier will come up with something that we can do better, probably a new device that we can buy to improve our processes. It could be after a review of QMS documentations. It could be from an external or even an internal audit. These are areas these are ways in which you can be able to identify opportunities for improvement for our setups. Now, enough of that introduction. Let me now go through the requirements as we talk about possible implementation approaches. Now, I may not be able to go through all the requirements of risk when it comes to ISO 15189, but I'll try just to go through a few requirements and suggest possible solution implementation measures that you can use. And then if in case I miss out on anything, you can probably let me know at the end of this session and be able to answer. So the first section in the standard where we come across the term risk management is, clause 5.6, where we are told that the lab management, or the laboratory for that matter, shall establish, shall implement, shall maintain processes for identifying risks of harm to patients and also opportunities for improved patient care. So the standard requires that we come up with a process. And when you see a process, we are just required to have a structured way of handling or approaching risk management. And in this case, when you hear of a process, then the only way to structure that process is by documenting a procedure for risk management, risk and opportunities management. Now, this process should also end up with, developing actions to address both risks and opportunities. And I have given you examples of risks. This could be, blood transfusion reaction. An opportunity for improvement could probably be as simple as introduction of an automated way of, sample collection. Now, the other thing that we are told about in clause 5.6 is that the lab director shall ensure that these processes are evaluated for effectiveness and modified. And so we can go ahead and discuss any identified risks, any determined or yet to be implemented mitigations with our lab director, so that they're able to see whether whatever we have done is effective or not. And then, of course, when the standard says that we have to have a process for identifying, it means that at some point we'll be required to demonstrate what risk have we anticipated, what have we identified as possible risk. So a record of anticipated risks and opportunities is something that we can also have as a way to show that we have complied with the requirement. And we'll be talking about this shortly when we get to the third aspect of this presentation. Now, clause 7.1, very quickly, it talks about the laboratory, ensuring that they identify potential risks in all laboratory phases. And once those risks are identified, they shall be assessed, mitigated to the extent possible. And then once we have mitigated them, we shall also check what has remained and estimated it and also communicated it with our users as appropriate. So what we can do here is to have, the risk register that documents all the possible risks that we have identified, as well as the opportunities. And we're going to see an example shortly. And then for each and every risk that we have identified, we go ahead and show results of estimation and evaluation. So that is what the standard refers to as the risk assessment. And then for us to be able to effectively mitigate our risk, it means we have to establish the root cause. Why do we think that, for example, a blood transfusion reaction is likely to happen? Why do we think that a power outage is likely to happen? Those are some of the things that we need to document just before we start the mitigation measures. And then finally, like I've mentioned, after we have initiated the mitigations, we are required to evaluate, how much of this risk still remains. This is what we are calling the residual risk, and communicated whatever is remaining with our users. And you will wonder, how exactly do we communicate these issues to do with risks with our patients and even our clinicians? We can choose what to communicate. We don't have to communicate all the risks, all the 50 risks. We can just probably communicate what affects them directly in the process of managing their patient. When you go to clause 7.5, the standard requires that we must have a process for managing non-conforming work. Of course, non-conforming work is what we routinely call non-conformities. Now, one of the aspects to be included in that procedure or that process for managing non-conforming work is part B, ensuring that immediate and long-term actions are specified based upon the risk analysis process established by the laboratory. So as you consider the immediate action, as you consider the corrective action, one of the guiding, whatever will guide you is the risk associated with this nonconformity that you have. And so there are many ways of doing it, but one of the ways is including a section in your corrective action form where you identify the risks. And you can see, if you are looking at the presentation on your side, at some point, once you have done your root cause analysis, you'll go ahead and do extent analysis or clinical significance analysis and also risk analysis of this particular risk, so that you specify whether there are any risks associated with your nonconformity. For instance, if your nonconformity is an IQC failure, we know that for sure, if an IQC has failed, it has a risk of translating the same errors onto patient results, and therefore probably also causing a problem in the patient management. So if that is the issue, then you're going to specify that risk in your corrective action form. and you address it later on, now with a mitigation or a preventive action or an immediate action in the process of handling your nonconformity. So you can have that identified or associated risk as part of your corrective action form. When you go to 7.8, the standard, of course, requires that we ensure that we assess risks associated with emergency situations, which has the possibility of happening in our laboratory. And so what you can have in the procedure for contingency planning or contingency continuity and emergency preparedness planning, you can have a table where you list down all the emergency situations and the possible risks associated with that emergency situation. And then alongside that, you can have, the plans, the procedures, and the technical measures to make sure that the risk associated with this emergency situation are well handled. And then, as required by the standard, that whatever plans we have should be periodically tested to see whether they are capable of managing our emergency situation or even the associated risk, to see whether we are really prepared to manage this risk associated with the emergency situation. And of course, an example would be a fire outbreak, and you go ahead and list the risk associated, any plans that you have to manage that risk or to manage that situation, and the use of fire drills annually to periodically test our capability to handle that emergency when one day it happens. Clause 8.5 talks more or less what we have discussed, the actions to address risks and opportunities for improvement. And you start by identifying, and then you action them as indicated in clause 8.5.2. So many people who are implementing this standard, sometimes, we get confused why the standard had to be split and, talk about risk in different sections of the standard. But it just means the same thing, identify the risks, evaluate them, and finally make sure that they are controlled. That is the bottom line. Otherwise, the standard may talk about so many things, but what we need to understand is that for our setups, we have to identify the risks, and we talk about how to manage those risks in a few minutes. When you look at clause 4, although the standard does not necessarily call it risk, in this section of the standard, it uses the term threats in as far as impartiality is concerned. So the lab shall monitor its activities and its relationships to identify threats to impartiality. So when you talk about threats to impartiality, we are simply talking about, risks to impartiality. That much as we want to be objective, we want to be as independent as possible as a lab, there are so many threats, there are so many risks that will make us probably not to be so objective. So as we talk about other risks across the laboratory sections, we also need to talk about the risks to our intention to be impartial. And of course, if a threat is identified, the standard requires that we go ahead and eliminate, minimize, to make sure that this aspect of impartiality is not compromised, and also demonstrate how we are mitigating such threats. So threats in this case should also be handled the same way we handle a risk, and I'll be talking about that in a few minutes. So finally, as we come to the end, allow me to take you through the risk management process in a way that we have been able to apply in our laboratories here in Kenya and any other place where we have engaged our clients in risk management. So the risk management process is summarized as follows. According to ISO 22367, the version of 2020, that you begin with a risk management plan, you do risk analysis, risk evaluation, risk control, risk management review, and risk monitoring. But this is theory. Let us talk about now what do we need to do to manage this risk management process? So the first thing about risk management plan, as indicated in ISO 22367, when the standard requires that we have a risk management plan, we're just required to have a procedure for how to manage our risk, which tells us about the approach, which tells us about the risk management tools that you'll be using, the frequency of root cause assessment, the responsibility who will be doing it, and even the risk criteria. When do we say that this risk is major? When do we say it is moderate? When do we say it is minor? So as part of risk management process, that should be the first thing that we do, defining the plan, defining the procedures, defining all those parameters in our SOP. Now, secondly, is risk analysis, like we have mentioned. And risk analysis involves three crucial steps. The first one being process mapping. Because for us to be able to effectively identify the risks in our system or in our activities, in our service delivery, we have to first of all map out where does work begin, where does it end in this facility or in this particular section. And we'll do this for every phase, for every laboratory phase, and any other, hospital department where we get an opportunity to help them in identifying this risk. So, for instance, if you're talking about risks analysis in pre-examination stage, we'll go ahead and map out the activities that fall in that particular section. For example, this begins from the laboratory informing its patients and users of its services, where we share out our catalog, where we share out our handbook, where we share out our specimen collection manual. Now, that is where the pre-examination phase begins. That is followed by test requests by, our laboratory users. So once you have shared about them that we are open this time of the day, this is the test that we can do, they'll go ahead and do the test request. Once the patient arrives, we'll identify them, we will prepare them for testing, we'll go ahead and do sample collection, sample packaging and transport, sample receipt, if it is going to another laboratory. And then finally, we will prepare the sample, or we'll do pre-examination preparation or handling of the sample before it is finally analyzed. Like what we do, centrifugation and all that. So the first thing when you're doing risk analysis has to begin with process mapping. And colleagues, this is one step that we usually skip. And it is very, very important. If you just jump and start identifying risks, you might miss out on very crucial processes if you don't first of all map out the activities in your section. So once we have this map of where our work begins and where it ends, we'll now be able to do risk identification. And just considering the second action here, which is about test requests by clinicians, we will probably have a potential risk as follows: wrong test selection on the hospital information management system. And this happens a lot, especially in the wards where the clinician who saw the patient is not necessarily the one who will request the test on the system. They probably did a manual request form, or they wrote on the patient file for the nurses to complete the request now on the system. And so for every risk that we identify, we're supposed to identify also the potential effect of this failure, of this particular risk. So what will happen once we have this particular risk? And why this is important is so that you take sufficient actions to address it, having known the potential effects, having known the burden of this risk, you'll be able to take the appropriate actions later on. So one of the potential effects probably is overcharging of the patients, or is this probably delayed diagnosis, because once you realize that it was the wrong test that was done, you may have to, repeat the test again and probably take another 2 or 3 more hours to finally do this particular test. And then as you identifying the risk, you also mention what are the existing control measures at the moment. And remember, when you're identifying these potential risks, they haven't happened at the moment, but probably previously, with some historical data, you can tell that this problem has happened in the past. So one of the existing measures probably in one of these facilities is that the laboratory usually confirms with the clinician before they go ahead and do sample collection. But probably this happens only for the non-routine tests, the tests that are not routinely requested. But we know that this measure may not be effective for all the possibilities of this risk happening. Now, the final thing about risk analysis is risk estimation. And when we say risk estimation, we are just doing a rating of our risk based on 3 parameters. The first one being occurrence, severity, and detectability of our risk. So if, for instance, we are saying there's a possibility of a power outage happening, we want to ask ourselves, based on the historical data, how likely is it? In a scale of 1 to 5, we rate our occurrence. So in this case, of course, our risk is about wrong test selection on the system. And so probably we are saying this risk in a scale of 1 to 5, we want to give it a rate of 4 in terms of occurrence, which means it happens so oftenly. Severity has to do with the consequences. If this risk was to happen, what would be the adverse consequences of it? And again, in a scale of 1 to 5, you grade or you rate your risk. And then finally, on detectability or detection, as we commonly call it, we are talking about if this risk was to happen or before it happens, the measures we have at the moment, are they able to effectively detect the risk before it happens? If they're not able to detect it before it happens, are they able to detect this particular risk before it proceeds to cause harm to the patient? And so again, in a scale of 1 to 5, we are going to rate our risk. Probably we'll give it a score of 4. So our risk score then has to be the product of multiplying occurrence, severity, and detection. I know there are some labs that only consider 2 risk parameters, that is occurrence and severity, which is good up to some point. But imagine most of these risks that you're identifying are not very strange risks. These are risks you have identified in the past, and you probably have put in some measures. So it would be necessary to add now the third parameter, which is on detectability, so that you can be able to now qualify the measures you put in the past to see whether they are still effective to detect this risk before it happens. Now, once we have done our risk analysis, which we have explained, the requirement according to ISO 22367 is that we do risk evaluation. And when we are doing risk evaluation, the intention is to compare the risk score or the risk priority number, which you have identified, like in this case is 48 with our risk. And you compare this risk priority number with the risk criteria, which we said you already defined and established it in your procedure for risk management. So the criteria here can be different based on the considerations you have in terms of how many parameters you use to estimate your risk. So for instance, if you're using 3 parameters, you can have a category for 1 to 10. You can have another one for 11 to 20. These are risk category. You can have another one talking about any risk between 21 and 125. And this is where we talk about minor risk, if it falls between 1 and 10, moderate risk, if it falls between 11 and 20, and 21 to 125, we call that a major risk or a significant risk, which is unacceptable if it falls within that category. And in your procedure, you can even indicate what actions to take when those kind of risks happen. So like in our case, because it was 48, our score here was 48, based on this category, we would easily categorize or evaluate our risk and place it in the major risk category, which requires action within probably 10 days. So that is risk evaluation, comparing what you have estimated against the criteria that you have put in your procedure for risk management. Now, risk control is the other thing that you need to do, and risk control just involves root cause analysis and additional measures, taking additional measures. So, for instance, if our risk was, wrong selection of tests on the HMIS, then we go ahead and troubleshoot and discover that the root cause is probably the nurses are having inadequate information about our laboratory tests and how to do the selection on the system. And after that, you will go ahead and initiate the additional measures. Remember, we had another measure before, but for the sake of completely minimizing this risk, we want to take additional measures, which is probably, engaging the nursing supervisor to tell us, who can do this selection, and probably conducting a refresher training on these particular nurses. And that can be done to eliminate these root cause, and also finally be able to eliminate the possibility of that risk happening. Now, finally, almost finally, as part of risk management process is risk management review, which just involves, us telling our top management or our lab director of what risk we have identified, get some of the risks. Some risks may require resources, probably training, sorry, colleagues. I think my internet got off. So as I conclude, just a minute. So the other thing that you'll be seeking to get is confirmation of whether the risks and the planned mitigations are acceptable or they are effective or not. Then finally is on risk monitoring, which involves just checking the effectiveness of the implemented actions and estimating any residual risk. So assuming you did the retraining of the nurses who does sample test requests, and you retrain them on how to do the selection on the system, you retrain them on our scope as a laboratory, you will go ahead and estimate how much of that risk is still remaining. So probably from a score of 4 initially, in terms of occurrence, you may end up with a rate of 2 in terms of occurrence, a severity of 4, and probably a detectability of 1. And then you go ahead and multiply that to get the estimate of the risk, that is the residual risk. And of course, if you get an 8, it means that you have been able to reduce your risk into the minor category, So that is it. In terms of a summary, this is just what I mentioned, that you begin with the risk management plan, which you said you talk about the SOPs and the criteria and the approach, the risk analysis, which involves 3 things: process mapping, identification and estimation. Evaluation, which just involves comparison of what you have estimated against the criteria. Risk control, which involves, root cause analysis and mitigations or additional measures. And then discussion in the risk management review and finally, estimation of any residual risk as part of risk monitoring. So that is it. Sorry, I think I took longer than expected, but thank you so much for listening to me. I want to believe that you have learned something. You may go ahead and ask any question that you may have. Yeah. Over to you, Mukosha and Elvis.
Thank you very much, Mr. Kahara. That was very, very educational. Thank you. So because we want to keep time, I will go quickly into the questions within the chat box, and people can raise their hands if they have got questions that they want to ask. So the first one is from Lincoln. So Lincoln has asked, after compliance, 80% of service running is accomplished if you have competent servers. Okay, thank you very much. Then, wonderful presentation. Kindly share this presentation. Thanks. Okay. Grace us in the presentation, Mr. Kahara. Okay. Mr. So Remy Kimati, you can go ahead and ask.
Okay. Thank you very much, Kalunga. I have a question for Paul. How do we address residual risks even after taking measures? Because there's a residual risk that remains. How do we address it, and how do we communicate it to the lab users?
Okay, so Remy, you are breaking, but your question is about how to address residue risk after you implement your corrective measures, but your residue risk is still high, right? How do you address that? That's your question, right?
Yeah, that's my question, yes.
Okay, all right. Thank you very much. Monica, you can go ahead.
Thank you. So to Paul, maybe you can briefly tell us how you can do a process map, because I've seen that we also need to categorize our risks, maybe into management risks and technical risks. How would you do a process map for the management risk assessment? That is number one. And number two, I've had other sessions whereby some assessments are asking you to categorize the risks in terms of the 5 Ps, the place, the pathogen. How would you combine the biorisk assessment together with the general risk assessment so that you may have one register? Thank you.
Thank you very much, Monica. So, Mr. Paul, you can attend to the two questions that have been raised.
Oh, sorry, I think I mute instead of unmuting. So thank you, Remy and Monica, for the questions. Quite engaging questions. So the first one on how do we handle the residual risk if they are still high? So ideally, you're supposed to probably investigate the root cause for this particular risk again, because maybe how you established the root cause initially, maybe you didn't narrow down on the real problem. So go ahead and do the root cause again. But sometimes the root cause could have been okay, but maybe your mitigation and or how you did your mitigation is where there was a gap. So go ahead and review how you did your root cause and how you initiated the measure, and see how you can redo it just to make sure that you do it right the second time. In terms of how do we communicate it with our users, you're supposed to share it you can share it on email. You can share it in form of a table, at the laboratory reception. You can talk about it when you have the clinicians' laboratory interface meetings. And the intention of communicating with the users is just to, give them an assurance that, we still have a risk of blood transfusion reaction, but these are the measures we have put in place. We are still monitoring. We appreciate it can still happen as an incident, but you're on top of things. You have a few measures that you are trying to implement. If it is still high, it's good to mention that, this residual risk is still high. It is still beyond what we would accept in our criteria for risk evaluation. But you tell them and assure them that you are still monitoring and implementing the actions to reduce it to the minimal levels possible. On to Monica's question on how to do process mapping for management. Yeah, it's a good question, because for management, it is not like for analytical tests where we know, we start by mixing this reagent and this other reagent, and then you incubate for this period. Now, for management, the tasks are not they don't follow a particular path all the time. The management activities are very dynamic, because today in the morning you're handling a complaint, another time you are receiving visitors into the laboratory. And so what you can do for process mapping in management is to highlight all the activities that you do in whichever order, because I know that you don't follow any particular order sometimes when you are doing the management activities. Just imagine all the laboratory activities that you have in terms of management in your facility. List them in whichever order, and try to point out where it can go wrong. Like, what can go wrong when you're managing a customer complaint? What can go wrong when you are, entertaining one of your guests into one of the laboratory offices? What can go wrong? They can interfere with the impartiality and all that. So that is probably how you can do process mapping, listing down all the activities. In terms of how do we manage this risk that is guided by ISO 22367 and the one on biorisk management, the standard requires that we get guidelines from both. And like we are saying, when we are doing risk identification, do it for all the sections, including health and safety, or biorisk, as you call it. And you can go ahead and, merge it with any criteria that has been given in that particular standard. Now, remember, ISO 15189 mentions that there is no one specific approach that is acceptable by this standard. Laboratories at this point can use any hybrid methods to manage their risk, but probably, you never know, in the next revision of this standard, we might end up with a more guided approach on how to handle our risks. So I hope I have answered that. Mukosha, I don't know if there's any other burning one.
Yes, there is a burning one, and I think Douglas has actually spoken my mind, because I was about to ask this. So Douglas asks, how can a laboratory balance resource limitations with the need for continuous risk mitigation?
Okay, do I answer it right away, or can I wait?
Yes, you can answer it right away, because we don't have any hands, and that's the only question that we have.
Okay, thank you. Also, of course, I can see Maureen asking a question also, but
Oh,
so
yes,
thank
there's
you,
also, I
Douglas.
just forgot. Sorry, before that,
Yes.
there's also something from, sorry, Collins saying, can Paul share an approach to risk associated with pre-examination phase for referral requests? Yeah. So that's the question.
Okay, so
Yes.
all right. Let me try to answer both Collins and Douglas. I can start with Douglas' question on how do we balance resource limitations with the need for continuous risk mitigation. So first of all, Douglas and colleagues, in everything we do in the laboratory, let us not put the issues of resources at the forefront. if we put the issues of resource availability at the forefront, there's nothing that we'll ever do, because everything we do requires some resources to be provided. So just like any other laboratory activity that requires resources, what we need to do is to prioritize, because the standard also talks about us managing our risk according to some priorities. We may end up with 50 possible risks in our labs, but these 50 possible risks don't all have the same risk score. That is why it is important to carry out a risk estimation to know how much of each of these risks have. And then we can prioritize, the major risks first before we come to the other risks. So probably that is how I can answer it. But there is a stiff competition of all the resources that we have in our laboratory. We just work with priorities. So priorities, priorities, priorities. The question by Collins on whether share an approach to risks associated with pre-examination phase for referral requests. I don't know whether I got the question correctly, Collins, but I can try to answer it this way. Now, for all the laboratory functions, all of them, from pre-examination to post-examination to extra examination phases, the approach is the same. If you decide to have, the same process of identification, estimation, evaluation, all the way to risk monitoring, you will do it across all the phases and all the functions for the laboratory. So I may not know exactly the issue about the referral request. I don't know whether you mean I don't know. Probably, Collins, you can verbalize the question as we think about it better.
Maybe it could be that there's a lab that is sending to another lab, and then the problems are coming from the lab that is the one that is sending. So now, if you're the receiving lab, how do you handle that? Is there an approach?
Probably Collins can tell us, Mukoshi.
All right. Okay.
I don't get it.
Also, so Collins has agreed to it. He says that's it.
Okay.
Yes.
All right. Thank you, Collins. Any other that is burning from your end, Mukoshi?
Yes, there are hands, Maureen and Wilfred. So Maureen, you can go ahead. Then Wilfred can come in. We can't hear you, Maureen. We can't hear you. Your mic, it sounds like you're very far from your mic.
Can you hear me?
Yes, now we can hear you.
Yeah, thank you so much, Hara, for the presentation. My question is, what is the definition of harm? Incident is defined as something unplanned that could have resulted in harm or injury, but not. Now, in a lab set, I'm looking at a scenario like maybe a slippery floor where someone fell and maybe was hospitalized for days, or maybe a fingerprint from a positive hepatitis B sample. So, in actual sense, we normally record this in our incident register, categorize them as incidents. So, under ISO 15189, how should we categorize this as accidents or incidents? We need to have like a separate incident.
Sorry, Maureen. I can't hear you. So I can't hear you clearly. Would could you try probably to go closer to your gadget? I don't know. You speak like you are too far away from your gadget.
Well, I don't know where the issue is, but maybe we should go first, then as I try to sort it out.
Okay. Okay.
Okay, so Mr.
Yeah, so
Wilfred, you can go ahead.
All right. Hello, everyone. Hello, Paul. How are you? Can you hear me?
Yes, we can.
So, my question is, can internal audit be part of that is in terms of risk identification, mitigation, and also the process on that is the outcome? As you mentioned, that is on the days, for example, if it's a minor risk, and the days we need to close, or is a major risk, and internal audit play a part of the same? That's my question.
Okay.
Okay.
All right. As we wait for Maureen, maybe Mr. Paul, you can tackle Mr. Wilfred's question and also Mr. Collins' question.
Okay. All right. Thank you. Thank you, Wilfred. Whether internal audit can be used as a mechanism to identify risks? Yes, yes, yes. There are different ways of identifying risks. There's where we sit around as a team and brainstorm on what can go wrong. But now, also during the assessments, whether internal or external, this person who is auditing the system can also capture potential non-conformities, potential failures, or the areas we say there's something you have done, but you haven't done it completely. So to answer you directly, yes, internal audits can be used as ways to identify risks. I can see Maureen, you're back. You can go ahead. Maureen, we can't hear you.
I think she hasn't just dropped her hand from the previous one. So, Mr. Paul, did we talk about did we
Sorry,
talk
am I
about
audible?
Mr. Collins? Maureen, you can go ahead. Sorry.
Okay, now my question was, according to the definition of term, incident was defined as an unplanned event that could have resulted in harm or injury. Am I audible?
Yes,
Yes,
but
we
we
can
have
hear you, Maureen.
feedback
Go
from
ahead.
your other from your other device, but this device is audible.
Yeah, so my question is, normally when we have incidents such as someone sleeping on a slippery floor, or maybe a finger prick injury that from maybe a known positive sample, we normally record it in the lab as a incidents. So are we supposed to have like a separate accident register book and not categorize them as incident according to ISO 15189 2022? Thank you.
Okay, thank you, Maureen. Thank you for putting effort to make sure you ask the question, even with the challenges with the gadget. So first of all, in many organizations, their register, they usually call it accidents and incidents log or occurrence books. They just mention occurrence books generally. Because sometimes it is not very easy to put a boundary between an accident and an incident. Because like we said in the definition, an accident is what will proceed to cause harm. You see, like a patient is already gotten the injury in terms of the finger, the needle prick. So you will call that an accident. But you see, sometimes it is probably a minor one where it was just by a slip of the needle and you got some injury. So some will call that was an incident because you never got any infection. Others will call it an accident because in any case you got the injury. So it is not always easy to differentiate the two, the accident and the incident, but just have them recorded, whether you choose to do it in the same log or not. But of course, what we are saying is that accidents and incidents are different from the risks. The risks are the potential, the accidents and the incidents are when they have already happened. So I hope I have answered that. In the same breath, I think I saw Ayub's question. Allow me to look at it, Mukoshia. Is there any difference in risk management and incident management? Of course, there is a difference because for an incident, we are saying it has already happened. And so if it's a needle prick injury, we are going to process it now, with the exposure procedure, testing the patient who was involved, recording in the incident form and all that. But for the incidents, remember, we are just anticipating failure. And so there's a whole difference in terms of how they are managed.
There's another question from Monica. Kindly help us understand, can risk assessment be an annual or an ongoing activity? If ongoing, how and when do we do evaluations or reviews?
A very good question, Monica. That is still troubling many of us who are trying to implement the standard. Now, the standard is not very clear on the frequency of when do we do risk identification. But there are two ways to look at it. You can have the structured one where you do it probably once or twice in a year. But remember, when you go back to clause 7.5, anytime you have an unconformity, you should also look around to see if there's any associated risk with that nonconformity. So you need to have both registers. If I was to answer you directly, Monica, have a register where you do these planned risk management, risk assessments, but you can also maintain another register for when you encounter an unconformity and you are required by the standard to identify a risk. So it is both ongoing. It can also be scheduled according to your own procedures. Yes, Mokoshia, anything
Thank
else?
you very much. So we don't have any hands in the group and we have short time by 13 minutes. Sorry, there's one more which we can look at from Lenga. It reads, kindly expand on the detection in the risk estimation. My network was bad. I dropped off when the explanation was given.
Okay. Thank you, Mulenga, for taking us back to the part of risk estimation. So let me scroll back and as I try to explain to you. So we mentioned that when you are doing risk estimation, there are two options that are used across different facilities. The first option is where you use two parameters to estimate your risk, that is occurrence and severity. And that is usually encouraged for a new system, for a new quality management system that hasn't done so much in terms of initiating mitigations for any risk before. Otherwise, once your QMS start rolling out and there are so many measures you have already put in place, it is necessary to also rate the already existing measures to detect these risks that are likely to happen. So, for instance, we are saying that you have a mechanism for preventing needle prick injuries. So assuming needle prick injury is the risk, you know, you have already gone ahead and introduced the closed system of sample collection. Now, when we are doing our risk estimation, specifically for that particular one about risk needle prick injury, we want to also assess, besides the occurrence and severity, how capable is our existing measures to detect or to prevent needle prick injury at the moment. How capable are they? How adequate are they? So I would say detection is more about checking the adequacy of the existing measures. Because in most cases, you'll find there is no risk that you haven't put some actions in one way or another. But what matters is how adequate or how sufficient or how capable is the measures that we have put in place. So if your measure is so capable, then you are going to rate it as 1. But if your measure is not capable either to detect or to prevent this risk from happening, we are going to rate it with a score of 5. So I hope I answered you, Mulenga.
All right. Thank you very much, Mr. Kahara. So to everyone, we will share the recording and we'll also share the presentation. Thank you very much once again for joining us today. And thank you for participating. We hope to see you in the next session for the discussion. Good night, everyone.